Well, it all started in 2005. I had trained as an infectious disease doctor at the beginning of the AIDS epidemic, and then spent the next 35 years teaching, taking care of people with HIV, and doing the research that made HIV eventually a manageable chronic disease with medication. And it was an incredibly rewarding experience because we were able to turn HIV/AIDS from a invariably lethal disease to a chronic one that could be managed with medication. Today, the majority of people living with HIV in the United States are over 50. So this story begins with a 2-week stint as the chief infectious disease doctor at University Hospital in early 2005. In that period, I saw 4 people with endocarditis. That's a lot. A lot of cases in a 2-week period. Endocarditis is a serious bacterial infection of the lining of the heart and the covering of the heart valves. Their risk for endocarditis, it was shooting up opioids. Opioids are prescription pain pills and heroin, other street drugs. So I started to work on development of a syringe services program in Cincinnati to protect people who were injecting drugs from serious bloodborne infections. I knew that injection drug use would lead to rapid spread of HIV if it entered that community, because in fact, blood is a more efficient way of transmitting HIV than sex is. And I should mention that Cincinnati was not a needle use town. You know, heroin had been a Cleveland thing, a Pittsburgh thing, a Detroit thing, but it was not a Cincinnati thing. So I became an addiction doc. And after 9 years of effort, we finally opened the Cincinnati Exchange Project in early 2014. Meanwhile, in late 2014, in nearby southeastern Indiana, an HIV epidemic was emerging among people who were injecting drugs in rural Scott County. By 2017, this had amounted to 228 newly diagnosed HIV infections, and 95% of these individuals also had hepatitis C. Scott County, in fact, was the first major rural HIV outbreak in this country. So the CDC proceeded to do a study to see if they could identify other rural counties that were at high risk of having an HIV or hepatitis C outbreak. And it turns out that hepatitis C is really an excellent marker of injection drug use, because by the time you've been injecting for a year, you have a 70% chance of having acquired hepatitis C. So it's very tightly tied to injection drug use. With this analysis, they came up with a list of 220 counties. And as you can see from that big red blotch, more than 50% of them are in central Appalachia. So we are, in fact, the epicenter of these combined epidemics. Of West Virginia's 55 counties, 28 are on that list of 220. And in fact, many of them are among the top 25. So this represents 51%, a little bit more than half of West Virginia's counties. Well, for some, opioid use started with prescriptions, but as the demand increased, there was a shift to street trafficking of pain pills, and then from swallowing pain pills to grinding them up and snorting them, and from snorting to injection. In fact, as Sam Quinones describes in his eye-opening book, Dreamland, that describes the origins of what I call the 21st century heroin epidemic, pill mills had become an easy source of prescription opioids in rural Appalachia. Wholesalers dumped millions of pills in West Virginia. The slide shows you that McKesson, one of the 3 main wholesalers for opioid drugs in a 6-year period, delivered over 100 million pills to this state. And we only have 1.8 million people. That's a pretty frightening number. In Kermit, a town of 392 in Mingo County, 5 million opioid tablets were dispensed in a 2-year period from 2006 to 2007. Due to a changing environment, from easy prescribing to crackdowns on pill mills and unscrupulous physicians, prescription opioids, such as OxyContin and Percocet, became scarcer and more expensive, eventually costing $1 or $2 per milligram. So that means if your person's going to get high on an 80 milligram OxyContin tablet, it's going to cost between $80 and $160, and that's just for a single dose. So this is where the pizza delivery model comes in. It was the introduced, readily available, cheap, high-purity heroin that typically sold for $10 a dose, and sometimes free samples were given out to new prospective customers. The new pizza delivery model of drug dealing: you call a phone number, you meet a car at a specific place and time, and you give the driver the money, and he hands you the heroin that's tied in a balloon in his mouth, and he carries it in his mouth in case he's approached by the police, he can swallow the evidence. By now, West Virginia, and especially the southern coal fields, are awash in people with the disease of addiction, and with the associated epidemics of overdose deaths, for which West Virginia has the highest rate in the nation, and epidemics of hepatitis B and C, for which West Virginia sadly also has the highest rate in the nation. So what do we do now here in West Virginia? I would say that the time for hand-wringing and head-in-the-sand posturing is over. We need a robust program that offers testing without stigma or shame to diagnose HIV and viral hepatitis. Because despite our efforts to provide syringe services to prevent this from happening in Southern Ohio, we were too late. One thing I want to emphasize that I hear a lot is that harm reduction does not enable drug use. I hear all the time from people who oppose syringe services that this is just enabling drug use. But that's absolutely not true, okay? People whose brain circuitry has been rewired in a way that drives the need to inject drugs will use syringes wherever they find them, in the street, right? In a syringe disposal box, wherever. They don't need a sterile syringe to inject, but they need a sterile syringe to avoid being infected. So if you want to prevent the acquisition of hepatitis C, you not only need a source of sterile syringes, you also need clean injection supplies, the cookers that are used to dissolve the drug over a flame, and the cottons that are used to filter the drug prior to injection. We are in desperate need of harm reduction programs. Harm reduction is the public health principle of minimizing the harm from unhealthy behaviors without stigma and without coercion. For people who inject drugs, harm reduction can mean overdose prevention education and the broad distribution of naloxone, which is the overdose reversal drug that saves lives. Harm reduction really means keeping people alive and healthy until they're ready for addiction treatment. It's hard enough to have one chronic disease, the disease of addiction, but then to layer HIV or hepatitis B or hepatitis C on top of it, it is really a burden. And many people who inject drugs have intercurrent mental health issues as well. So, in a way, you're making it even harder for them to recover and lead relatively normal lives. But screening for the infections associated with injection drug use is not enough. Individuals with HIV and viral hepatitis need to be linked to care. And by that, I don't mean referred to care. They need to be actively linked to care. While hepatitis B and HIV can be medically managed, hepatitis C can now actually be cured even in people who inject drugs. All it takes is a pill a day for 84 days. Now, this is quite expensive, and initially the cost was $84,000, so there was a lot of press about the $1,000 pill that you had to take for 12 weeks. But the price has come down. The average price now is closer to $20,000, and even with that big reduction in cost, insurers still deny curative therapy to people who inject drugs. I think largely because of concern about reinfection, but maybe also possibly because of bias. But if people who inject drugs have access to syringe services, to sterile syringes and clean injection equipment, that should be enough to prevent reinfection. And we are currently doing a study here in Morgantown to prove that. So far, everybody has been cured, and so far, none of our patients have relapsed or become reinfected, although at some of the other sites in the country there have been some reinfections. Access to evidence-based addiction treatment is sadly very limited in West Virginia, although that's not really different from anywhere else. Statistics have shown that only 10% of the people who need addiction treatment ever get it. That's a pretty small proportion. So we urgently need an expansion of these programs to meet the need. Medication-assisted treatment for opioid addiction has been proven to save lives. So 2 of our counties will open new syringe services programs this spring. And I have to tell you that working with the staff of these health departments has been exciting and rewarding. And these individuals who are largely from these communities are absolutely dedicated to curbing the opioid epidemic in their county. And they're wonderful, and they're an important part of the future control of this problem. Many cities, counties, and states have sued the opioid manufacturers and the wholesalers that unconscionably deluged their communities with prescription opioids. Just this week, the Attorney General announced that the Justice Department will also take action against the opioid manufacturers. So legal redress, in fact, may be coming. And Purdue Frederick, the manufacturer of the infamous OxyContin, has said it will no longer push their drugs to doctors. That's called detailing, when salesmen come around and try to convince you to use their drugs. So what more can we do as a community to lead with hope in a changing world? Certainly research is part of the solution. New approaches are needed. That's quite clear. But all of you can be part of the solution too. Stigma and shame keep people with the disease of addiction from getting the help they need. In many ways, the stigma associated with opioid addiction reminds me very much of the things I heard in the AIDS epidemic, right? It's a lifestyle choice, it's immoral, God doesn't love them, et cetera, et cetera, et cetera. So you don't have to be poor and homeless to suffer from the disease of addiction. Really, it's an equal opportunity disease. And like all people with serious chronic diseases, these individuals need our compassion and our support. It's up to all of us to speak out for those who can't do that for themselves, to join forces to deal with West Virginia's #1 problem, and to make this state a better place for everyone. Thank you.